Good afternoon, everyone. We're just waiting for people to join. While you're waiting for your colleagues to join, we'd love it if you'd introduce yourself in the chat. If you're representing one of our member organisations, a big shout out to you and do let us know. I'm in Ngambri today, on Ngunnawal and Ngambri country. We'd love to know where you are, so please pop that in as well. We will be asking you for questions. We've got some already, but we'll be asking you for questions. So if you have a burning question as you wait for your colleagues to join, feel free to pop it in. In a moment, we'll start. Noticing there's still more people joining, but we'll start so that we can leave plenty of time for your questions. Okay, welcome to folks just joining. You can see the housekeeping instructions there on the slide. Just give you about another 10 seconds and then we're going to start. Thanks, Liz. And a big shout out to our New Zealand colleagues who are joining us today. So as I've said, I'm in Ngambri, Ngunnawal and Ngambri country. I'd like to pay my respects to elders both past and present. And also I'd like to acknowledge them as the traditional owners of this land. I'd like to acknowledge the continuing relationship to the lands and waterways here. I would also like to pay a big, warm welcome and respect to any First Nations people who are here, and that includes any First Nations people from any other countries that are dialing in, as well as Australians. Thank you. Okay, so I am here. My name is Elizabeth Devaney. I'm the CEO of Consumers Health Forum. We are a national peak body whose job it is to represent the views of Australians in relation to their health and wellbeing, and we advocate to the federal government in order to improve that. So today's webinar is on AI in healthcare, and I'm sure it won't come as a surprise to anyone that the future of healthcare is increasingly going to be digital and heavily shaped by technology. We know that artificial intelligence, or AI, can improve things, but we shouldn't assume that that'll be the case. And the question for me is always, does a service, a model of care need transformation? And if it does, is a digital mechanism a good way to do that? Or is the transformation more about something else? For example, changing the culture in the service, changing the funding mechanism. There are lots of ways to transform a service. When a digital mechanism is a good idea, then the question is, well, would AI, particularly today we're going to be talking about generative AI, would AI be a good way to do that? So we're going to probably just touch the tip of the iceberg, but begin to discuss a lot of these key issues. Before we start, I would like to do a quick poll to see how you are thinking now about artificial intelligence in healthcare. So there should be a poll there now for you that you can complete. The panelists and I can't actually vote, only the rest of you, so do please vote. We're going to ask you how familiar you are with AI in healthcare, and we'll come back to you later on with the results. So I'm just going to give you a moment to find the poll, have a quick look at the questions, decide what your answer is, click on that button, and then we'll move on. Okay, hopefully you've had time to vote. We have got an amazing group of people here today to speak to you. And as always, we want to hear from you. So do introduce yourself in the chat. I can see we've got about 120 people here and about 30 have introduced themselves on the chat. So there's another 80 of you. I'm expecting you all to pop a note in the chat. Say hello, tell us where you're coming from, who you're representing, anything else you'd like to share. We'd really love to hear from you. So I'm waiting to see that little red number go up to 120, and then I'll feel like we've all said g'day. If you've got a question for one of our chats today, please pop it in there. We'll be looking at that. We'll be taking those questions. Sometimes if we get a few, we might theme them up. And towards the end of the session, we've got a Q&A where we'll be asking questions of all the panelists, and we'll be able to direct your question to a particular panelist if you're someone in particular you'd like to answer your question. So think about your questions, pop them in there. If we get really busy towards the end, sometimes we don't always get to answer all the questions, but they're never ever wasted. We use these to guide our advocacy work and sometimes to help us in the development of other surveys, do a whole range of things. So any ideas are really welcome. Pop them all in the chat. Hopefully we'll get a chance to answer them today, but if we don't worry, we will use it in some other way. The other thing I would really love you to do is use the reactions for some live responses as the speakers are speaking. So I'm going to test you all now to see if you can find your reactions button, and you're free to use any reaction, but just put one up right now to make sure that you know how it works. We did this a few weeks ago with Minister Butler, and I asked him, did he like all the love? And he said, I'm not wearing my glasses, I couldn't see it, which, was, a little funny. Look at all those lovely reactions. So I can tell you, as you can see, I have got my glasses on, so I'll definitely be able to see them. And so I'd encourage you to use them all throughout the session. Thumbs up, thumbs down, whatever you're doing, we're delighted to hear what matters to you, what are the good points, the things that need to be applauded, the things that concern you. So don't let that be the only time today you use that reaction button. Set yourself a goal, try and use it a few times during the session as people say things. We're going to do a few things today. Firstly, we thought it might be good to just start with a couple of things about the definitions we'll be using. People use a lot of jargon when they talk about tech. We can't cover all of that jargon. Welcome, Inga, but we can cover some of it. So we'll talk a little bit about that. Then you're going to hear from our panel members. Each will give a short presentation about something related to artificial intelligence in healthcare. And at the end, we'll have a lot of time, hopefully, for your questions. So I can see a couple of people starting to put questions in the chat. Keep popping them in so that we can harvest all those and use them for a really lively session at the end today. So let's get started on some of the key terms for AI in healthcare. So some of our panel members have recommended some globally recognised references for today. So we'll put the link in the chat for this. Some of these are from Stanford University. And I'll walk through these for you, and you can look at that link in your own time, or you might use it as a helpful reference in future or when people are talking to you about AI. So first of all, this notion of AI or artificial intelligence really first coined, believe it or not, in 1955, which is, I can say, well before I was born. So we think of it as a modern phenomenon, but of course, people have been talking about this for quite a long time. John McCarthy, who gave it this name, said, it's the science and engineering of making intelligent machines. So at a simple level, that's really what it is. So now we understand it as a branch of computer science that focuses on creating machines, computer programs, software programs that can undertake tasks that normally humans would do. Chatbot. I don't know about you. I spent 2 hours almost with a chatbot on the weekend trying to sort out a small problem. Anyone else had that experience? Let me know with the reactions if you've had good or bad experiences with chatbots. A chatbot is a software application or a web interface that mimics human conversation. Well, mimics, I think, on the weekend was a very strong word for what I had going on. But anyhow, it tries to help, and I'm sure it was trying really hard. The other one, and I've got teenage children, there's a lot of conversation about this one, ChatGPT, and how it can do your homework for you. It's a chatbot, really, developed by OpenAI, which is a large organisation, which can generate human-like text based on context and past conversations. It uses what's called a large language model and is an example of generative AI, and that's the kind of AI we'll talk about a lot today. So let's talk about generative AI. So generative AI is AI that learn the patterns and structures of their input by training on data. Might be text, images, something else. And then they generate new data relying on what they've learnt from that training. Sometimes they can do things they haven't been taught to do by just simply harvesting the learnings from that data as they go. We talk about language models too, like large language models. You'll hear this, or sometimes just the acronym LLM. You might have seen that somewhere. So this is a type of AI model that's trained on massive amounts of data and can be adapted to perform a whole lot of different tasks. So ChatGPT is one of those. Google has one called Bard. You might have used that. That's also a large language model. Machine learning is the last one I want to mention here, which is a method that helps machines learn. So there's a way to teach machines to learn this information. and to get better at doing things as they go without explicitly being programmed. So years ago, we would have thought being a coder or computer programmer was a job for life, and hopefully it will be. But increasingly what we all know is that we can ask computers to do things without having to learn a complex coding system to do that. I remember, does anyone remember things like DBase decades ago, and using various kinds of things, Pascal, Python, all kinds of things, in order to get the information you needed to build a report? Anyone scarred by any of those experiences in the past, perhaps? Well, the idea behind some of this and the machine learning is the machine learns to do things. It doesn't have to be programmed. And so it means that everyone can harness the benefit of technology in a way that perhaps they couldn't have many years ago. Now I've got our last couple of definitions, and these come from our very own Department of Health in Australia. So one is health technology. So what do we mean when we talk about health technology? Health technology is a really broad term, and it means something that's intended to prevent, diagnose, or treat medical conditions, promote health, provide rehab, or organise the delivery of healthcare. So health tech includes tests, includes medical devices, medicines, vaccines, blood products, procedures, programs, and systems. It's very broad. The other term we often hear used is digital health, and replace the old e-health. Again, I've been around for a while. I remember e-health and even the PCHR. Perhaps some of you will remember that also. Let me know if you do. So digital health refers to using technology to improve the healthcare system for providers and patients alike. So telehealth, electronic health records, e-prescriptions and referrals, electronic medication charts, all of these things are examples of digital health. So, phew, that was a lot of information to take in. I hope you're still with me. Your eyes haven't glazed over. I hope it was useful, because these words do get battered around, and it's helpful sometimes to have a starting point to say, when we use these words today, these are what we're really talking about. This is what we mean. And our presenters, of course, who are experts, will help us make sense of some of this, and no doubt do a much better job than I just have. So before we get to our first presentation, I really want to introduce Jen Morris, who's joining us today as a consumer leader and representative. Jen is a community representative working in the health sector with a particular interest in patient safety and patient harm prevention. She's got 14 experiences of bringing these views and voices of community and service users to a range of different tables. She's done phenomenal work, particularly in research, education, policy, governance, regulation, and safeguarding in the healthcare sector. So it's really great to have you joining us here, Jen. We appreciate you being with us today. And I really wanted to get your quick thoughts about these definitions. I think for many people who don't have a solid understanding of AI, it can be complex. How do you think of AI and its role in healthcare?
Thank you, Elizabeth. And to your point about chatbots, and a hot tip for everybody here, I have no tolerance for chatbots. I've only ever had bad experiences with them. And so the only thing I ever type into a chatbot is talk to a person, talk to a person, talk to a person, until I'm allowed to do that. So that's my strategy for that, but maybe I'm a Luddite. But yeah, to your question, I think, you know, I've been increasingly being asked questions about artificial intelligence in healthcare in the last couple of years. And I know from the consumer's perspective, I'm not alone in that regard. And I still continue to learn new things about the nuances and the overlaps and what's a subset of what and all of those things. Even today, you know, listening to you talk about that now. So I think it's something that some people are experts in, of course, but the majority of us are not. We're new to it. It's a new world, even for digital natives like myself. It's a whole area that all of us intersect with. Very few of us are experts in, which is always an interesting place to find ourselves. And I find that thing about 1955 really striking, because it's not entirely new to me, but it does make me think, you know, why is it that we're doing this today? Why is it that we've reached this kind of point in society in general and in healthcare in particular where this is such a big topic of conversation? You know, and I've been asking myself about what has changed that we're doing things like that. And obviously the technology has, and I'll allow people who are much more expert in that to talk about that. So I'll set that aside and think about what else has changed. And I think one of the things that has changed in terms of potential impact of the types of technology you just talked about is about, you know, from 1955 till now, when it was chess and checkers playing programs, that was the AI, to now, is the ubiquity of computers in general and this technology, you know, more broadly. It's existed most of our entire lives, but the ubiquity of it has changed, and the instinct people have to trust computers has changed. I remember hearing about, in the 60s and 70s, a lot of concern about computers, what they were going to do. A lot of, sci-fi came out in that time about the evils of computers, but we've become much more relaxed into the idea of computers. And that has, different implications as well. And I think the other thing that's changed is the high stakes context in which we see this. When it was playing chess, not a massive big high stakes situation. But if you think about, what's happened recently, not necessarily AI, but computers, what I would argue two of the biggest public administration scandals of recent times, the Horizon postal situation in the UK and Robodebt in Australia, involved essentially powerful entities weaponizing but the computer said against vulnerable people. And I think that's something that has changed both the way the technology is received by the public, but also what we understand its implications can be. But the other thing I want to talk about the definitions you've given is I think we talk a lot these days about generative AI, et cetera, and we'll be doing so today, and I think appropriately so. But yeah, it has this spectrum, right? From anyone who's old enough to remember Clippy, who used to say, "You look like you're writing a letter. Would you like help with that?" That was a very primitive AI, but it was. Through to Siri telling me how to get somewhere, in Google Maps, to, Horizon type scenarios that unfortunately have really tragic consequences. So I think the definitions remind me that it's important for us to keep that full spectrum in mind, and focus on the ones that we think have the greatest risk or the greatest benefit, or potentially both, when we decide, where we put our energy and our time.
Fantastic, thank you. And thanks to those that were brave and put a few reactions in there. When you're giving a presentation in a webinar, you can see no one's faces. You don't know if they're liking or not liking what you're saying, if they want to, amplify it. So it's really great as people are talking, and also at the end, I see you're getting a bit of love there now, Jen, for people to let you know if you're saying something that they agree with or not. It's just super helpful. So thanks for everyone that's doing that. Indeed. So I'm going to go now to our next speaker, is Dr. Roy Sugiharan Marathias. And I'm really delighted to have you here with us today, Roy. Roy's a fellow of the Royal Australian College of General Practitioners, and he sits on their expert committee for practice technology and management. So you can see the college here getting ahead of the curve and thinking about what the impact might be for all of us, including GPs, with AI and tech. So some use post-fellowship in clinical practice. Roy made the leap, I don't know if it was a big or a small leap, interested to hear, to tech entrepreneurship, and founded a startup that was using artificial intelligence to automate workflows for doctors and also their patients. So I'd like to hand across to you now, Roy. I'm very excited to hear all about your journey. Thanks.
Thank you so much. Thanks so much, Elizabeth, and great to be here and speak to everyone today. I'm a GP. I sit on the RACGP Expert Committee for Practice Technology and Management, and I also am the founder of a startup that's exploring the use of generative AI to reduce administrative burden for doctors. We know there's huge problems with the amount of burden that doctors face, and burnout as well, from a workforce perspective. Also, I'm a member of the OpenAI forum, and I recently had the privilege of attending some talks on responsible AI and AI in medicine and imaging at Stanford. And so just got to see the latest research, use cases, and hear the arguments around specifically the use of generative AI in healthcare. So what I'm going to share today is really about what we're seeing in Australian general practice and what patients are using. I do have a presentation, so if you bear with me, I will pop that up. Yep, there we go. All right, can everyone see that? Okay, you're probably not going to say yes or no. Yep, we've got a thumbs up. Thank you, guys. All right, so I'm going to talk about AI scribes and the consumer use of ChatGPT. Lots of thumbs up. Thank you. That actually really helps. Okay, so first of all, yep, I've covered Stanford. large language models have gotten very, very powerful. This is a graph showing the ability for question answering on medical questions for board certification, I think in America. So we're talking like USMLE. The data set that they're testing on is around 14,000 English questions, and then 34,000 and 14,000 Chinese questions respectively. And we're starting to hit scores of around 94%. This kind of, I won't go into the tech, but there's a really interesting paper that came out recently on the use of a multi-agent AI pipeline to help answer these questions. And essentially they set up a hospital. So the technology is becoming really, really powerful. We're not seeing the use of this yet for clinical decision making. And it's certainly not happening in Australia. And I would say clinical decision making at scale in terms of a product that's been put into the market, or a peak body that's released something. But you can see where things are leading to and going. People are trying to find help with decision making from a medical perspective. And yeah, I think eventually we will get there. There are problems with the use of generative AI and large language models, and I won't cover them in my presentation, but you'll hear some of the issues with the use of these later. So what are we seeing in general practice in Australia? We're seeing GPs and specialists take up what we called an artificial intelligence scribe. So you might have heard products like Otter, Gong, that summarize your meetings on Zoom, you're starting to get these emails, really annoying emails with meeting summaries. There's a thumbs up for the annoying emails. But yeah, it's similar to that in a medical consultation. So basically, a patient will come into the consultation. The doctor will ask for consent to use this AI tool to record the consult. The doctor will then have a consult with the patient, all of which will be recorded. And then after the consultation is finished, these products, or the large language model, along with whatever pipeline is behind the product, will convert this into a medical note. And so doctors are spending less time on documentation than they were before. Now, like, it's pretty interesting. First of all, there's like anecdotal feedback around, yes, this helps me. There are early adopters. There are some naysayers. There are some people that find that it helps them. There are some people that find that it doesn't. And yeah, there's a number of products. It's really easy to, I guess, create these products. So the barrier to entry for startups is quite low. And that can also present itself with concerns. We've seen some GPs create products, not that they can't, but I'm not sure if I'd want a GP coding a product. And we've seen some people with no health background create products. And so yeah, you've just got to ask yourself, and not that any one of these people are unable to do so, but there are pros and cons with this. So yeah, the outputs are interesting. They can be liable to hallucinations. One story that I heard was a letter was signed off as the world's greatest cardiologist. I found that quite entertaining. But you can see where potentially what was not in a consultation might be produced. And so there might be certain aspects of a consult that normally would be part of a consultation be written down. And so basically things that never happened can be reported on. On the flip side, things that normally would not have gotten picked up or might have been missed in documentation will get picked up and documented clearly. I've used these tools myself, and I would say I find them particularly helpful for very long consultations that carry some form of medico-legal implication. And so when I need to be a little bit defensive, these tools are like highly helpful in order to yeah, like provide some really in-depth documentation. That's what we're seeing in the United States. There's 34 of these companies. Australia has 9. I would say that the States has really started to roll this out across health systems, and that's been interesting. And there's varying kind of feedback from implementation across health systems. Yeah, I guess one of the things that I would probably bring up in this forum would be to think about consent. You know, how do we ensure consent at scale? And sorry for hearing that. How do we ensure a proper consent process at scale for patients? And also the kind of technical back end of this is what is happening with the data? Is the data sovereign? Where are patients' data going to? You know, are some startups or even doctors using other transcription tools to help them with their documentation, and where is that going? Is it meeting privacy requirements? Because barrier to entry is quite low. So that's the first use case, and the second use case is these are some other considerations which I've kind of talked about, but the second use case, which I don't have a slide for, is the consumers using ChatGPT. So what I guess with generative AI, what we are seeing across the board is that search is getting disrupted. So generally, where we used encyclopedias at one point, we might have sought experts at one point, and then we saw consumers across the board consulting Google, and there was very much a lot of memes around Dr. Google. It's quite a pain point for doctors to be competing against Dr. Google. And so this is a phenomenon where patients would go and kind of conduct their own research. Usually there would be kind of very mild symptoms, but they would Google their symptoms and usually come back fearing that they had cancer, and then present to the doctor's office for reassurance. And now I guess what we're seeing is that across the board with generative AI, people are not turning to Google as much, but they're using ChatGPT and this conversational experience to retrieve information. I would say that, yeah, there are some companies out there that are creating or making search a lot better than what we've conventionally seen, and that's quite exciting. But when we're typically going to a large language model, let's say a consumer is going to ChatGPT and asking questions, if there is no way for that model to reference websites or resources, then it is pulling on its own training data. And if that training data is incomplete, it will create a very interesting sounding answer. And so we've had these examples of yeah, that I've seen really funny and maybe not so funny examples of people asking ChatGPT if they can put porcelain into breast milk or baby formula, and it's kind of given this a very obscure answer and highly dangerous answer. Yeah, so it can get things wrong. But what we have seen is consumers are starting to do this and use this. I guess the interesting dynamic is that where there is burnout and where there is a lack of access, consumers will look for other solutions. And so broadly, it's a systems issue. Zooming back in, when patients are using this, there is no way if they are speaking to ChatGPT for them to verify that these answers are correct. And so when you have a highly intelligent answer being presented to somebody with potentially a low level of health literacy, or even a vulnerable person. And some of these models are multilingual as well. So you might be able to even get a verbal response in a different language, or see your own language. So these are highly convincing answers, but there's no backup, or they're not grounded in fact. That can be quite concerning. And I guess that problem is being looked at today as well, and so the accuracy of answers is improving. There are different technological solutions for that, and I think it will improve over time, but it's definitely not there yet, and it's something to be very aware of. Two other points before I finish. The first is that there is a company called Perplexity, and this is kind of like the new Google. And if you were to type in a medical question in this search engine, then it would essentially do a Google search and then summarize responses and come back to you. And so you're seeing where these resources and references are coming from. And it's a lot more reputable than asking a straight large language model. So use cases like that, I think, are a lot better than a consumer going to ChatGPT. And the other note, the other point I've forgotten, so I think I'll just stop there. Happy to answer any questions afterwards, and thanks again for the opportunity. Hopefully it was helpful.
Thanks, Roy. There's a heap of questions in the chat, and we'll come back to some of those later on. I am going to ask you just one, which is, how do these kinds of scribes deal with people who don't speak English as a first language, where the conversation might be in another language or mediated or translated? Could you just give a quick answer to that, and then we're going to keep moving.
Yeah, sure. So when they are becoming multilingual, we could say they're multimodal. At the moment, we tested this the other day. GPT-4, which is one of the newer models. My mum spoke in Tamil to GPT-4, and I had this on the app, and she was having a conversation. And the experiment was that she had a headache and she wanted to book a doctor's appointment. And I have to say, it handled it extremely well. So in terms of access, I think there's huge implications for patients that speak other languages, even in terms of real-time translation and accuracy of that.
Fantastic, thanks. Now, Jen, I'm going to throw to you, and I wonder if I could get your thoughts quickly about what stuck out to you in Roy's presentation.
Thanks, Elizabeth, and thanks, Roy. Yeah, I think as per my introduction, one of my main areas of interest is patient safety, and particularly communication and its impact on patient safety. And one of the things I'm thinking about listening to Roy is about, do we know what impact having, for example, a scribing type software or program that Roy was talking about? Do we know what impact, that would have on depth of listening? Because all the, research I've ever seen into diagnostic error and what happens with diagnostic error, as an example, depth of listening, real, accurate human listening is a contributing factor in many, if not most, diagnostic and patient safety harm situations. And I wonder, and I don't know because I've never done it, whether or not knowing that the computer over there is taking my notes for me affects how actively somebody is listening to what's happening. And you might think, well, does it matter how actively they're listening at the time because the notes will be there for them later? But active listening in the moment changes the questions you ask in the moment too, and the direction you take. Do you pick up the nuance? Do you pick up the subtlety? Do you realize the euphemism, Do you realize the figurative speech is figurative? A lot of that nuance in that moment. So I don't know the answer, but it makes me wonder about that. And I think the other thing that, that just listening to Roy speak, thinking about the consent issue, and consent having an opt-out side rather than being, I'm just going to tell you that I'm doing this, that's okay, kind of, yes. And what that would be like to be the patient that I have been, where I've said, actually, I don't want you to use that technology. And the power dynamic that comes with that, and the aggravation on the other end for the clinician that comes with that, and how difficult that is as a patient to basically say to somebody, no, I'm not going to let you use the technology that makes your life easier, quicker, And that's a very difficult thing to do as a patient, something we should have the right to do. But it does create an interesting and difficult power dynamic with that person when you've said to them, I don't want you to use this technology that you're just used to using. So yeah, just some interesting things to think about, Elizabeth.
Fantastic. And you're getting lots of love there and lots of thumbs up. So a lot of people agreeing with you. And Vivian, yeah, the idea of empathy. Someone once thinks you should be bottled, I think, and sold, in every health environment. So fantastic. So thanks. I'm just going to put the results of our poll up on the screen now too for you to see, because it's always nice to see. So we've got a few people not really familiar at all. A lot of people thinking they know something about it. Very few, around 12% saying they're very familiar. So just thought that might be interesting for you to get a sense of where you fit, and also us a bit of a sense too of how familiar people are or confident they are with AI. We're going to move on to our next speaker now, Professor Farah Maghrabi. So Farah is a Professor of Biomedical and Health Informatics at the Australian Institute of Health Innovation at Macquarie University. Whew, that's a mouthful. I'm glad I don't have to do that every day, Farah. She has a background in electrical and biomedical engineering and has worked as a health researcher for 20 years. And Farah, like Roy and Jen, is just pure gold. So I'm really delighted to have her here today and hear her speak. At the Institute, she leads research to improve clinical safety and the effectiveness of digital health and AI for clinicians and consumers. So without further ado, take it away, Farah. Thank you.
Well, thanks very much, Elizabeth, for the opportunity to come along today. So I'm coming to you from Macquarie University's beautiful Wadamadagal campus. I'm going to try and address some of the issues that have been raised in terms of, how do we go about using AI safely in healthcare? We live in tremendously kind of interesting times. The health system is under enormous pressure. AI has a potential to solve some of the intractable problems that we face in healthcare. And against that background, we have tech giants. There's a race on in the background where they're building ever more powerful AI. If you're reading the news headlines, every couple of days something happens. More and more of these AI are being integrated into everyday consumer products. If you're looking at the news yesterday, Apple is now going to integrate more of generative AI in its products. And so it remains to be seen whether it's going to help us or make things more difficult for us. But it's a consumer product. And when we're thinking about healthcare, I think we want to assure ourselves that these things work, that they're fit for purpose before we deploy them in healthcare settings. So against that background, I just want to kind of remind ourselves, we're thinking about AI as computer systems performing tasks that typically require human intelligence. When we're thinking about safety, we really want to look under the hood and sort of work out how these computer systems, get to that helping us with tasks. The AI we're talking about today is essentially machine learning, which is making inferences from data. So essentially learning up patterns from the data. And I'm going to keep coming back to that because a lot of machine learning we have today is relying or is built on health data. But we also have emerging foundation models which are built on general data, but are being applied in healthcare. And we'll come back to that. With the AI that we have already in clinical settings, it's worth looking at the role of that AI. And this is important because Jen talked about Robodebt, where decisions were being made by the computer. In healthcare, we're sort of not quite there yet. The AI that we have, especially the AI that is helping us deal with information, is largely assistive. And I think it'll remain that way for some time at least, because clinicians are relying on these AI as one more source of information. Even if they're using it to generate records, it's assisting them. It's not completely taking over their job. So the AI we have today, there's a lot of it integrated in medical devices already. It's one example is an AI that provides information. So it's essentially reading images, X-rays, CTs. So the example I have here is a CT that is an AI that looks at CTs and is calculating, different lung volumes and lung lesions. The second group, and this is by far most of the AI we have today, they assist clinicians. The example here is an AI that is interpreting an ECG for abnormal cardiac rhythms. It's meant to work side by side with clinicians. And if we look at the intended use of this AI, it clearly says that clinicians mustn't use the AI-generated output as the primary interpretation. The responsibility for the final decision relies on the clinicians, essentially saying, look, this is one piece of information. Look at the patient in front of you. Consider everything else before you make a decision. The vast majority of AI we have today fit in this second group where they're assisting clinicians. We also have AI that provide decisions. The example here on the screen is an AI that looks at the back of the pictures of the back of the eye, so to detect diabetic retinopathy. So it's actually making a decision or a diagnosis. And with AI like this, we can provide screening in places where specialists are not available. So really improving access to services. At Macquarie University, we've done quite a bit of work looking at the safety risks of these AI. So this is data coming out of the US Food and Drug Administration, so post-market surveillance data. We looked at safety events over a 6-year period and sort of essentially plotted them out against, where do these safety issues with AI kind of come from? And so starting on the left-hand side, is it to do with the use of the system? Is it being used correctly? Is it related to data being fed from other systems into the AI? Is the issue with the algorithm itself, or is it the output? And by far, the majority of the safety issues actually come from bad data being fed into AI systems. Yes, we do have issues with algorithms too, but it's bad data being fed into systems. But what's interesting is use errors or problems with the use of these systems. They only were about featured in 7% of the events, but they were 4 times more likely to harm patients compared to the technical issues. So it again comes back to, how safely and how well these AI are being used. These clinical AI are based on traditional machine learning algorithms. They train specifically on health data for a specific task. So if I have there's a lot of effort that goes into curating data to train machine learning algorithms for health. So essentially what it's saying is I'm using apples and oranges here, but essentially when you want to train a machine learning model for a healthcare task, you curate a data set to define what you want to feed into the AI and what output you're expecting. So you curate the data, you train your model, and then if it's presented with, so the example here is an AI that it's trained to detect pictures of fruit. If it's presented with a fruit that it knows about, it'll correctly detect that output and give you that answer. This is a little bit different. So you can see it's trained to detect the entire sort of picture of the fruit. So this is a little bit different compared to foundation models, which is what ChatGPT and other generative AI are based on. So these foundation models are trained on general data. So it's like all of the data on the internet, and then they're fine-tuned for specific tasks. Let me explain that a little bit. So if I have a foundation model for text, it's essentially trying to predict the next word in a sentence. If I have a foundation model for images, it's predicting the next pixel in a picture. And similarly for music, it's detecting the next kind of note in that piece of music. So there's a large number of foundation models, both in private hands and open source available to download and use. And the latest version we have from OpenAI is GPT-4 Omni, which is kind of the most powerful. It's now even sort of being able to, show capability to behave in a more human way and sort of be more empathetic as well. So essentially what happens is these foundation models are then fine-tuned to perform specific tasks like answering questions, summarizing information, and labeling images. So if you take ChatGPT, it's based on this GPT-4 Omni model, and then it's trained to answer questions. This is me having a bit of play with DAL-E, which is a foundation model for images. They essentially respond to tasks. So I asked DALL-E to generate me a picture of a sunflower wearing sunglasses on a sunny day. And so you can actually have quite a bit of fun with these models. But what this shows us is that these models are generating responses or plausible responses in response to requests. So what we need to keep in the back of our mind is that they're generating statistically plausible responses to complete a request, and that they do not model logic, they do not model facts or laws of the physical world or any morality, because all it's doing is it's trained to detect or trained to predict the next part of a sentence or a next image, pixel in an image, and it's not looking at the big picture at all. But just because it's trained on so much of data, they perform extremely well for a large number of tasks, as we've already heard. So let's kind of look at a couple of examples using generative AI for answering health questions. So if I had, I'm imagining myself to be a consumer. My dad has just been diagnosed with Parkinson's disease. And so how do I kind of help my dad? So if I do Google search, I can go in and type that question. And of course, Google will sort of bring up links to reputable, sort of credible websites. And then I can go through and click on those links and sort of try and answer my question. It's giving me links to answer questions. But if I go along to ChatGPT, it's already there. It's saying, hello, how can I assist you today? It's already waiting for me. I ask my question, it gives me a response. And it sort of starts off being really empathetic, telling me that, here's it's challenging. There are many ways. It'll start listing a number of ways. And then at the end, it sort of, again, reassures me that, look, take these steps. Remember, every person's journey is different and you need to tailor this to your specific needs. And that was such a, you can see it's a much nicer user experience in terms of finding answers to clinical questions. But let's just do a quick comparison. I've sort of drawn up a little table. I'm thinking about user experience. So what do I put into this AI? What do I get out? And is that information kind of credible? So let's look at web search first. Web searches are pretty good. They actually do understand questions these days. But what it's giving me is links to information, some excerpts. I need to kind of sift through those links and really kind of piece together the answer for myself. But the good part of it is the information source is verifiable. I can go through and find Australian links to better support my dad who's been diagnosed with Parkinson's. If I go to ChatGPT, it responds to my question. So it gives me a proper response. It maintains state. It remembers what it said, and I can go and ask it follow-up questions too. The response itself is appropriate. It's very structured. It's giving me I can sort of say, here's 9 steps, go and do this. It's actually informative, it's directive, and it's also very empathetic. The only thing is it's a black box. It doesn't tell me from where it's got that information. And if it's something that I can verify, then I'm okay. But if it's something I can't verify, then obviously I'm in trouble. But look, the tech is developing very, very quickly, as Roy sort of reminded us. There are now foundation models that are trained specifically, or they're fine-tuned on medical data. So it's only getting better. We're not quite ready yet, but the user experience is fantastic, and it's kind of watch the space because it's coming. When we look at clinicians on the clinician side, so the use of generative AI for clinical documentation, as Roy kind of described to us, these can be quite useful for record keeping, for writing referral letters, for also generating custom kind of patient information. So I'm thinking of, like a GP wants to explain something to you. Some of the really good GPs will sort of draw out a little diagram to explain what's going on. So I'm imagining something like that where they might generate sort of customized information. As Roy reminded us, a lot of these, especially in the US, they're already kind of being trialed in clinical settings in terms of carefully implementing and looking at whether or not they're valid and useful within the research and evaluation framework, because they do have a whole lot of issues, and we need to sort of, again, make sure that they're valid and fit for purpose. So one of the first ones that emerged in the literature was this sort of implementation and evaluation at Kaiser Permanente. So this is a large network in California. What they did was they had a very sort of good process in terms of, so they had a research, they kind of did an implementation in a research and evaluation framework. They had a 2-week pilot. They implemented the system, they kind of tried it out, they sorted out issues around consent. So the stuff that Jen talked about earlier on, you know, what happens if a patient doesn't want this? So what is the work process going to be like? They sorted that out over a 2-week period with some clinical champions. And then over a 10-week period, they implemented this to about 10,000 clinicians. And the evaluation is sort of still underway, but from what has been published to date, exactly like what Roy was sort of telling us, they do have enormous potential in terms of improving the clinician interaction. So both clinicians and patients were quite happy overall with the system, but they also documented instances of hallucination. And I just want to finish off with those here. So here are some examples where the doctor mentioned scheduling a prostate examination for the patient, and the AI scribe summarized that the prostate examination had already been performed. Another example is when the doctor mentioned issues with the patient's hand, feet, and mouth, and the AI summary recalled that the patient had already been diagnosed with hand, foot, and mouth disease. And the summary was missing some important details of chest pain and anxiety. And then another example is where the summary was not consistent with a pre-existing template. So it's essentially resulting in inconsistencies in summarization. So these systems are already available in Australia. Clinicians are using them from what we know. And so it's worth kind of keeping in mind that these tools based on generative AI, they're trained to generate text that is statistically possible to complete a request. When AI is summarizing consultations, this is not the same as a transcript of the conversation with the patient, because it's essentially taking that whole conversation, but then, summarizing it down. And so it could be adding information, it could be missing out important information. And so ultimately, it's only there to assist doctors. And so they need to carefully review and verify the output provided by the AI before accepting it into their record system. And as I said, this is very, very early days yet. Studies looking at the validity and the accuracy of these systems for clinical settings are already kind of underway in terms of evaluation studies. And so, we wait to sort of see what it's kind of a watch this space at the moment. And so where does that kind of leave us? So just to summarize and conclude, clinical AI is being applied in many areas. Alongside rule-based and statistical reasoning methods, we now have machine learning methods that clinicians are using. The applications of foundation models in generative AI, well, they're emerging. And it's an exciting and an important space. It solves a very important problem, but we need to carefully validate these systems and ensure that they're fit for clinical purpose before we adopt them. But at the end of the day, when we look at AI, I think it's going to come back to the role in clinical tasks. So are they providing information? Are they assisting clinicians, or they're actually providing decisions? And so far, we're still in the middle space where they're actually assisting humans to make decisions. And so the first question we want to ask is, are they fit for purpose? What are they trained on? And how well do they perform for the particular kind of task at hand before we accept them into clinical settings? And so as far as safe use goes, whether it's clinicians or consumers, what we want them to be able to do is to verify and confirm the AI provided information. I know that's a tall ask, but for clinicians at least, because they're, I guess, informed users, they should, that's essential, especially if they're using generative AI in record keeping. And for consumers, well, we need to, again, get a bit better. I think it's about having general understanding and improvement about AI. And we need general generally as a community to improve digital health literacy digital literacy as well as health literacy. So let me stop there. Thanks very much.
Thanks, Farah. That was a terrific view and a kind of a lovely walkthrough. You're getting a lot of love there on the screen of some key issues for us to think about in relation to AI. I'm going to throw straight across to Jen and ask her for her thoughts.
Thank you, Elizabeth, and thank you, Farah. You've always got a great way of making that stuff really understandable that I appreciate, so thank you. I think, I guess the one thing I want to draw out of Farah's presentation is on the notion that, AI is only as good as the data from which it's drawing, or from which it's trained, or whatever, language we want to use. And I don't want to make 2 points about that. One is that, we know from research studies into medical records, if we take them as one form of data from which the AI can be trained, 15 to 40% of medical records entries, not entire records, actual just single entries, contain factual errors, right? And that's before we take into account bias, poor clinical reasoning, sloppy note-taking, transcribing errors, medical legal defensiveness, all the other things that dirty the quality of medical records. And I guess for me, it's about that rubbish in, rubbish out question, and just my personal view that I don't think our medical records data, at least, is close to ready to be valid for uses like this, and I think that's something we have to grapple with as a system and as a society. And then relatedly, and this is a genuine question, Farah, maybe for later in discussion, because I don't know the answer, it's about how do we get these systems to unlearn things when we need them to unlearn things, most particularly because medicine and science and society are growing, evolving and changing things. And so there would have been a time when every reputable source would have told an AI that was trying to learn that stomach ulcers are caused by stress and that the way to deal with that is for people to reduce their stress and spicy foods and blah, blah, blah. Then science discovered actually it's bacteria, and we had to have this kind of epoch change around our understanding of stomach ulcers, which is hard. Medicine doesn't have a great history of learning those things. It takes 15 to 20 years to undo that kind of thing. And my question is, in the time when that happened, as an example, there would have been one research paper that said, actually, it's bacteria, and a million other sources saying, actually, it's stress and you just need to eat less spicy food. And what it is that we do about that in teaching AI that, no, ignore all of that now. These 3, 4, 5 bits of data are the new truth, and getting it to understand that. And I think about the modern example of that would be around the data out there that AI would learn from, would tell it that women particularly, but people with endometriosis have high rates of anxiety, right? That's what the data says. What we're starting to learn and understand finally about sexism, misogyny in healthcare is that actually lots of those women just have endometriosis and had their pain misdiagnosed, misattributed to anxiety. So there's unlearning that needs to be done there. So I guess my question, not for now, but for everybody, is how do we unlearn things when we need to because of scientific change or social change? And is that harder or easier for humans, machines, etc. to do? Thanks, Elizabeth.
Fantastic. Thanks, Jim. We'll come back to your question. So Farah, we're going to ask you that in a little while and keen to hear your thoughts, but I'd like to move across now to our final speaker, Professor Stacey Carter. So Stacey is the founding director of the Australian Centre for Health Engagement, Evidence and Values, and the Professor of Empirical Ethics in Health at the University of Wollongong. Again, long titles, eh? Stacey works at the intersection of 3 health system challenges: using AI, screening and diagnosis, consumer and community engagement and participation, including things like deliberative democratic approaches, which is one of the things I love about the work she does. Since 2019, her team's conducted extensive research on the views of Australians about AI in healthcare, including running the first national citizens jury on healthcare last year. So over to you, Stacey.
Thanks so much, Elizabeth. And I'm just going to share my screen. So thanks everyone for being here today. So I am in fact going to tell you about that National Citizens Jury, which Farah and Jen also were involved in. So this is the first time there'd been a National Citizens Jury to ask the people of a country what they wanted to see around the implementation of artificial intelligence in healthcare. And I want to tell you what we did and also what people said when we asked them. So this work has been published in the MJA fairly recently. If people would like more information, you can follow that URL and that will take you to a website that will give you more information about the project. I'll show you that URL again at the end so that you'll have another chance to click it for anyone who hasn't managed to click it now. So I want to tell you a bit first about deliberative democratic methods, and these are methods that come from politics and government. They're not traditionally methods that are used in health. They're based on the idea that the fundamental idea that is shared across the consumer movement in healthcare, which is that people should have a say in the policies that affect them. That's the fundamental principle. And these are methods that are intended to make government better, to make democracy better, by getting policymakers, getting government to listen to people, but in a really well-informed and structured way. So the principles are everyone should have a say in the policies that affect them, and everyone should have an equal chance to have a say. So the way that that's operationalized is to randomly invite households in an area that's affected by a policy to participate in a deliberative process. But it's not just an equal chance to have a say that matters. It's also making sure that the final group is diverse and inclusive. So that's operationalized through stratified sampling. That is, of the people who reply, we very carefully select a smaller group that has enough diversity across all kinds of important demographic characteristics that we feel that we've got the inclusion that we need in the room. The process needs a clear purpose so that people know what they're being asked to do. So we craft a question, or often it's called a remit, and that's what we ask the people that are selected to focus on in the process. It's really important, because we want this process to affect policymaking, it's really important that it be based on balanced, high-quality information. So we provide participants with access to experts and resources so that they can learn a lot about the topic and have their questions answered before they're asked for an opinion or before they're asked to participate in deliberation. There's a recognition that this takes time and that you actually have to learn to do this. You know, like often people don't have many opportunities to engage like this around these often quite technical topics. So we provide people with a lot more time than you typically would in a social research project, for example. People engage for weeks or sometimes months in these processes. And then the intention is that the outcomes will guide policy making. So we support the participants to make sure that what comes out the other end is policy relevant recommendations that can then be used to try to affect the direction of policy in an area. So as Elizabeth said, we ran a citizens jury in 2023, and this is the question that we asked the jurors. Under what circumstances, if any, should artificial intelligence be used in Australian health systems to detect or diagnose disease? So you can see we focused the question on disease detection and diagnosis to kind of bound it a little bit, and we gave people examples of those sorts of AI. And we left the question very open so that people could come to whatever conclusions they thought were most important. We used an independent third-party organisation that specialises in these kinds of processes, and they sent invitations to all of the places where there's a yellow dot on that map of Australia. So they sent out 6,000 invitations, and they used an algorithmic system, somewhat ironically, to select a group of 30 people that was very closely matched to the demographic criteria that we set. And people were very diverse on many different demographics. So I just wanted to show you, and this is with permission from both the photographer and the jurors. This is some of the jury. Not everyone wanted to be photographed, and not everyone could be at the final meeting of the jury. But this gives you a sense of some of the folks who were participating in the process were part of making the jury recommendations. So in running a citizens jury, it's really important to take people through a series of supportive steps that allow them to be in a position to make good recommendations together. So people need to understand the purpose of the process. They need to build relationships. You know, this is fundamentally a social process where people are working together. They need to build skills to be able to exchange views, sometimes have difficult conversations about differences in values, about tensions and trade-offs. They need a lot of opportunity to interact with information, and then there's time to deliberate together and to formally make decisions together about what the outcome's going to be. And then beginnings and endings are very important. So there's always a closing ceremony where people get to deliver their final recommendations and have that sense of really completing a difficult job well. So for this jury, everyone who participated worked for at least 24 hours, spread over 18 days. Before people engaged, we sent them a booklet, and that booklet included the 4 case studies. We gave people lots of phone and online support. We gave people lots of support to participate. So for example, if people didn't have a good device, we sent them a device and we sent them data so that they would be able to participate in the online components. So the first part of the process was online. There were 3 interactive sessions on Zoom, and there was also a bulletin board that was running for 2.5 weeks where people could interact with each other and with information. And then the second part was a face-to-face meeting of 2.5 days where people had opportunities to really work through all the issues and decide what it was that they wanted to recommend. And this is what the jurors produced. So the jurors made 15 recommendations in 10 categories. And you can see the categories here, but I'm going to take you through them one at a time, so I won't read them out on this slide. This was developed very much bottom up. It started with a conversation about what are the most important areas where we need to make recommendations, and then further conversations once that was decided around what should those recommendations be. So here's what the jurors recommended. The jurors wanted to see an overarching charter and framework. They wanted a charter for AI in Australian health systems and services, and they wanted that to be overseen by an independent body. So this was about good governance of AI, and governance was really important to the recommendations, across the recommendations that were made by the jury. The jury thought it was really important that benefits and harms be balanced, and they expressed that in terms of continuous evaluation to make sure that both patients and healthcare professionals were experiencing more benefits than harms. People wanted to make sure that fairness and bias, the potential for bias creeping into these systems or them being implemented in unfair ways, was addressed by ensuring that there was a universal right for access to the benefits of AI in health systems. People wanted to make sure that patient rights guidelines included addressing the right to have access to effective, safe AI. There was a lot of concern for clinical governance and training. So training for healthcare workers, oversight by the professional bodies who regulate those workers, and mandatory monitoring, auditing and reporting processes, and lots of things that needed to be measured in that monitoring, auditing and reporting. There was also concern about the regulatory process and making sure that regulators were scrutinising systems regarding both what they were meant to do and how well they were doing it, and that those systems should only be approved if it meant that the healthcare system worked better than it did now, if the performance of the healthcare system would not be degraded by the implementation of an AI system. There was a real concern, going back to what you've just heard from Farah and from Jen, with where did the data come from? Where do the data that we know that these AI systems have been trained on come from? And there was a concern that those data sets should capture the multiculturalism and diversity of Australian society to make sure that these models work equally well for everyone. There was a preference for free and open source software. There was a desire for really high quality evidence, and again, wanting representative Australian data to underpin that evidence wherever possible, because we know that models don't always travel well from other places, from one place to another. So that there's a real need to make sure that models will work well here for the people that they'll be used on or with. And making sure that there's really high quality evaluation of these models, that it's not about hype, it's not about someone promising big things for what these models can do, but instead keeping to the high standards of evidence that we have in the healthcare system for the performance of devices, for the performance of practices, making sure that we can actually evidence what these systems are doing. And that's not oversold. And then finally, the jury called for comprehensive, fully funded community education programs. And importantly, this wasn't just about a didactic telling of the community what they needed to know. It was about bringing the community along and making sure that the community could actually actively participate in the governance of AI that was so necessary within healthcare. So this has been a big process. The jurors are still very much engaged. You can, again, scan that URL if you would like to get more information. We're continuing to speak to lots of policymakers about the output of this process, and I'm really happy to answer any questions.
Thanks so much, Stacey. I'm going to throw to Jen because she was involved in all of this too, and just ask you what this presentation brought up for you. Once again, you're getting a lot of love there, Stacey.
Thanks, Elizabeth. And yes, acknowledging my bias here that I had a much more smaller role than Stacey did in this project, but I did. But I will let the lessons from the jurors stand for themselves. I don't want to speak for them. Stacey's put that up very neatly and easy to understand there. So I think what I would just draw from this, what I think is really exciting about this process for me, is it is such a robust demonstration of the absolute necessity of consumer, community, consumer rep, whatever category you want to use, involvement, and if I may misquote a movie, everywhere, all the time, right? That's what this tells me, is that we have a group of people here who, when empowered by the democratization of knowledge, when given everything they needed to work with and entrusted with that information and entrusted with that process, given that respect as thinking, intelligent, life experienced adults, came up with a very nuanced, very considered, very grounded, very practical, understanding with a broad view about how do we make this work, how do we make this safe, big stuff in there about safeguards, about governance, about democratizing data, about equity and justice and evidence and oversight and all these things. And I think for me, it's just, I guess my message to the audience would be, and I'm not accusing anyone here of this, but, I struggle sometimes out there in the world with low expectations of consumers and community members, right? Would they understand? Could they understand? Would they understand the nuance? And the idea that people have simple drivers. Oh, if it makes their life easier and they can do their stuff online instead of going to the doctor, they'll love it. That's all they care about, And what this says to me is that is not fair and not accurate representation of where people are coming from. They do have an understanding of bigger picture, risks and benefits, controls, justice and equity and all those things. So I guess the message for me is, we can tell from these community members that they didn't like shiny tech just because it was shiny tech, right? They understood it was a much bigger picture. So if and when you are working with AI, those of you here, whether you're researchers, consumer reps yourselves, clinicians yourselves, whatever you are, this is how you do it, right? This is how you do it well, that consumer and community representation. You don't always have to do it extensively in this practical sense as Stacey's done, but this involvement of people all the way along, empowering them with knowledge and not having those low expectations and knowing they can contribute really valuably, I think for me is the message out of this. And I really thank Stacey for bringing that to the table today.
Great, thanks, Jen. Now we're going to have all of our panelists here for you to see and ask some of your questions. So I'm going to start out with the one about regulation. People have been asking making different comments about the regulation of AI, comments about hallucination, audit, what the TGA is going to do, all those general thoughts. So I'm going to throw to you all. I'll start with you, Roy, then I'll go to Farah, Stacey, and then come back to you, Jen. And I just want to if you can, a quick answer, knowing we've got just a bit over 10 minutes left, so try and get a few questions answered, which is, who should be the police for AI in healthcare? Really? That's really the question. Who should be regulating all of this? So who are you voting for, Roy?
I think it's the easy response is going to say it's going to be the TGA, but interesting, there was some research put out by some OpenAI researchers on responsibility on the safe use, and what they found was that there was a diffusion of responsibility in a lot of this happening, as in it's not me, it's you. So I do believe that it's all of us. It's consumers, it's the providers, it's the tech developers, it's the model creators, it's government. Like, we all need to take responsibility for this and regulate. I guess the industry body would be the TGA, and they're doing some good work to look into this, and already have done a lot of good work.
Okay, great, thanks. Farah, who do you think the police should be?
Well, look, it's the entire kind of system, right? And so there was an AI policy roadmap for AI in healthcare that was released by the Australian Alliance for AI in healthcare last year, and that's essentially kind of the main. It's got 16 recommendations, and recommendation number 1 was a national council for AI in healthcare, because a lot of the pieces are already in place. They need to be stitched together and coordinated. And so if you haven't yet seen the roadmap, I would encourage you to go along and look at it, because it's a consensus of all of the stakeholders in the sector, including the Consumers Health Forum.
Maybe you could put a link to that in the chat. That'd be great, Farah. And Stacey, who do you think the police should be?
So I'm going to endorse both Roy's position that we all have to take some responsibility, and Farah's that the roadmap's a really good direction. And what I'm going to add is that, so we need health-focused solutions, and there's lots of bodies that have particular complementing expertise around the regulation of AI in health. Then we also have to think about what sits around that. So there is an increasing appetite around the world, including in this country, for what's called horizontal legislation. So legislation that is trying to regulate AI as a technology across all domains. And there's also, this brings in lots of really important law that we already know is important in healthcare, like privacy law, for example. Like liability law. So there's lots of forms of cross-cutting regulation that are also really important. So practitioners and consumers, but especially practitioners, need to be aware of all of that bigger kind of mega structure around this. It's also a rapidly changing space. Everyone is trying to run to keep up right now. So I think there's going to be a lot of change in just the next couple of years.
Thank you. And Farah's put that link in for those that haven't seen the amazing roadmap. Now you can have a look. Jen, your thoughts?
Thanks, Elizabeth. I'm happy to endorse and defer to the other 3 answers if that will help you go on to another question.
Well, that's great, because the next question, I can start with you, was this comment about humans, really, and emotional support. And you mentioned some issues around active listening and the rest of it. So do you think that people's healthcare might suffer if we use AI more and more and people less and less?
Yes is the short answer. I think it may. I'm not claiming it will, but I think it may. I think I'm seeing some evidence of it already. I can't detail specifically where I've got that from, but working in kind of complaints and investigations sort of zone, I am seeing that start to happen, where people's experience is an iPad being thrust in their face and kind of, go deal with that in the corner. And then the clinician will kind of look at that and go, okay, here, here's your management plan. And, we know from clinical evidence out there, over decades and decades, that obviously there is actual scientific biological components of treatment that go into people doing, feeling and getting better, but that there are genuine benefits to feeling heard, feeling seen, feeling noticed, therapeutic relationship, all of those things. There's good scientific evidence for that. And I think we are at great risk of losing that, both to the technology in the kind of iPad in the face sort of sense, but also to the way that you're introducing, in one sense, a third party into that therapeutic relationship, the program, the iPad, the whatever. But depending on the data set, you're also kind of introducing tens of thousands to millions of other parties into that decision-making, being the sources of that data, the other patients and clinicians. And that changes the dynamic between the two people when there's these millions of other sort of unseen entities that are parties to that relationship. So I think it is a great risk, an understated risk, one for which there are mitigations, but I don't think we're talking yet enough about that.
Thank you. So Stacey, I'm going to come back to you and then I'll go to Farah and Roy. So I'm going to ask you, particularly just drawing on what Jen said about the risks. Those 10,000 new people that are in the consultation, anyone been on the internet lately and seen trolls, biases, sexism, racism, you name it's there. So what's the risk, particularly around, stigma, shame and bias if we rely more heavily on AI? Do you have any thoughts about this? That's for you, Stacey.
I'm so sorry, I misunderstood. We know that bias is potentially a systematic problem with AI models, and that is for a number of reasons. It can be because the data that we use to train the model are not well aligned to the characteristics of the people the model is being used with. But there's also really good evidence that if humans have been systematically biased, for example, systematically prejudiced against a particular portion of the population where they provide those people with less care or less quality care, perhaps not even realizing it, because, as Farah said, these are systems that learn from past data. They learn how to predict what should happen in the future based on what happened in the past. They will replicate that bias and potentially intensify that bias. That could be a good thing if we're looking for it, because it might actually mean that we see the bias that was previously invisible before. But it could be a terrible thing if we don't look for it, because it could just strengthen and intensify the bias, the prejudice, the systematic discrimination that's already in health systems. So I think AI is an inflection point for thinking about discrimination in healthcare, and we really need to take that seriously and use it as an opportunity.
Thanks so much, Stacey. So Farah, is AI a good thing or a bad thing? How are you feeling?
Look, I actually have a lot of faith in the humans, because I think that, like, just speaking, so I'm not a clinician, but speaking for the clinicians, I think people who, get into healthcare, they get into it for the people. And from all of the interactions that we have in studying AI that is being used by doctors, what we have clearly understood from a lot of the conversations and observations that we've had in our research is that they deal mostly with AI as one more piece of information. They're mostly looking at the patient in front of them, considering everything else, including their social and sort of broader context of healthcare delivery. And so at the end of the day, they make the right decisions for those humans. And that's kind of why they get into healthcare in the first place. So I think we need to make sure that the way that we implement and design these systems doesn't take the humanity out of healthcare. And it's not hard to do, because you can see the tech is kind of racing ahead. We need to, the interaction that we have with these technologies is improving a lot. It's improving every day, and it's possible.
So Roy, you're an early adopter, so one assumes you're very positive. Are you very positive about AI in healthcare?
I'm very biased and a techno optimist. I think we've got huge issues with supply and demand, and we've got workforce issues. I think we're seeing that we can't keep up with what we're I guess with the demand that's placed on doctors and nurses in the health system. So really, I see technology as a help to that. Now, I don't think we'll ever like replace clinicians, but I think we can seriously augment them and support them. And we're like, for a burnt out doctor, I probably should share. I've heard multiple stories of doctors, some who would be considered to be more stoic than others, crying the first time they saw this scribe, because they just realized how much of a burden it would lift off them. And for some of these doctors, it meant that they went home and saw their families for the first time in like weeks, on time, like they got to kiss their kids goodnight. And so I think, for that reason, I'm fairly optimistic. I think we've still got a long way to go, though. That's for sure.
So we've just about finished, folks. We'll be taking a screen grab in a moment as a way of thanking all of our great panelists today. I'd love it if you all can go really wild with your emojis now, so we can capture all of your thanks to the amazing panelists we had today. Just let it all out. See how many you can get out in the next few minutes. While you're doing that, in a moment, I'm going to share with you a link to a survey we're doing asking consumers about AI. And we would really love it if you would not only perhaps do the survey, but also use your own social channels or whatever it is and share that, so we can get as many Australians as possible to answer our questions about AI using our online platform. So I think someone's going to put that up for us in a moment. Thanks very much. And yes, the ubiquitous QR code, but don't worry, we'll send it out to you after the presentation as well. So I'd like to finish on time and do that by saying thank you so much to hear from our great experts, Jen, Roy, Farah, Stacey. Been really enlightening, terrific to have all of your ideas in the chat. I found today's session useful. Feel free to pop your own thoughts into the chat yourself about what was good, bad and ugly, because we're always up for the feedback. And we hope to see you again at one of our webinars sometime soon. So thanks very much, everyone.